Hello and welcome to this second online lecture organized by Context. My name is Camila and I'm a doctoral researcher at the Center for Global Health at Trinity College Dublin. Today we will be talking about conducting cultural adaptations for low-intensity psychological interventions. We will be talking about their importance and I'll be proposing a short methodology for doing this in a rapid way when resources and time are limited. Before I continue, I would like you to remember that attached to this lecture there is a case study, and that will give you more details about all the information that I will provide during this lecture. It is important that you read them, especially for answering the questions that I present at the end of the lectures, and that will guide your study of this topic. Before continuing, I would like to talk about the learning objectives of this lecture. I will be soon presenting a case study of population movement in Colombia, so by the end of this lecture, students should be able to describe the situation of population movement that has been presented. In addition, students should be able to define what low-intensity psychological interventions are, as well as to understand and reflect on the importance of cultural adaptations of low-intensity psychological interventions. Finally, students should be able to explain and critically analyze the proposed methodology for cultural adaptation. When talking about population movement and migration, the starting point is usually numbers or the magnitude of this phenomenon. Currently, the International Organization of Migrations estimates that 244 million people are migrants. 68.5 million, on the other hand, have been forcibly displaced due to violence, conflict, or persecution. Out of these, 40 million have been internally displaced within their countries, while 25.4 million are refugees and 3.1 million people are in the process of seeking asylum. During the last 10 years, Colombia has continuously ranked as the first or second country with the highest number of internally displaced persons globally. This is mainly due to an armed conflict that originated in the 1960s and was triggered by an interest in control over political power, natural resources, and drug production. This conflict is very complex and it has been continuously evolving during the last 5 decades. It has many actors, among which are left-wing guerrillas, the paramilitary, and government forces. Civilians have been the most affected by this conflict, which has resulted, as I previously said, in a very high rate of displacement. This pattern of population movement has been further exacerbated by the now more than 550,000 Venezuelan migrants who have fled to Colombia from Venezuela because of the socio-economic and political crisis. It is estimated that 442,000 Venezuelans do not have legal status in Colombia, according to a survey conducted by the Colombian government. In addition, in 2017, 652,000 Venezuelans transited through Colombia to migrate to other countries such as Ecuador and Peru. Finally, approximately 1,300,000 Venezuelans have a permit to cross between the border to Colombia on a daily basis. These are known as pendular migrants. The links between armed conflict and the detrimental effects it has on the mental health of people that are affected by it has been clearly established in the literature. Experiencing multiple stressful events such as physical assault or the disappearance or death of a loved one, as well as stresses such as poor living conditions and lack of social and material support, have been found to be associated with post-traumatic stress disorder, depression, and anxiety symptoms. In Colombia specifically, research shows that there is a statistically significant incidence of PTSD diagnosis among internally displaced persons in comparison to the rest of the Colombian population. Despite variations in the prevalence rates reported for disorders such as depression, anxiety, and post-traumatic stress disorder, evidence indicates a higher prevalence of all types of psychological distress among migrants. This is mainly due to factors that influence their well-being, such as perceived social discrimination, family separation, illegal migration, poor working conditions, or overcrowded housing. The other population of interest in this case study is Venezuelan migrants. However, information about the mental health needs of this population in Colombia is up to date solely based on anecdotal evidence. In a 2018 survey conducted by the Colombian government on Venezuelans without legal residence in Colombia, 99% of migrants indicated they were not attending any health services, and 3% of individuals self identified as having a mental health disorder. Civil society plays an important role in the provision of community based mental health services to internally displaced persons and migrants in Colombia. In particular, the Colombian Red Cross has played an important role as a mediator in the Colombian armed conflict, especially in the reporting of human rights abuses. But in addition, in its role as an auxiliary to the Colombian government, it provides psychosocial support and mental health services to internally displaced persons throughout the country. Moreover, it has played an important role in responding to the needs of the Venezuelan migrants recently, not only through the provision of food vouchers and support throughout the routes, but also in providing psychosocial support services. When thinking of which services to provide to these populations, we can think of many effective therapies that could help in reducing psychological distress among migrants and internally displaced persons, even if they have different backgrounds and have experienced different situations. However, in low and middle income countries, there are still many barriers to accessing mental health care. And although in Colombia, internally displaced persons, for example, may access a subsidized health system, there are still many barriers to their care. One of the reasons for these barriers is the lack of specialized personnel such as psychologists and psychiatrists. This could also have to do with the unequal distribution of these personnel throughout the country and throughout sectors. The lack of availability of specialized personnel has led to a growing interest in low and middle income countries in the models of task shifting or task sharing, which basically refer to the use of the already available human resources and their training so they can be able to facilitate more specialized tasks to populations in need. Although there's a growing interest in this model, the concept is not new and was, for example, used in China in the mid 20th century through workers known as barefoot doctors, and was very commonly used in Africa in the response to the HIV epidemic. Low intensity psychological interventions are also part of this model. They can be defined as simplified versions of evidence based therapists, and probably their most distinctive characteristic is that they do not require the presence of a skilled psychotherapist, but instead can be delivered by non specialized personnel such as nurses, volunteers, lay health workers, or teachers, always given that they receive the appropriate amount of training and supervision. This characteristic in itself increases coverage of mental health services. They also tend to be transdiagnostic, meaning they apply to a number of psychological needs. And this does not require the non specialized person to understand multiple diagnostic systems before applying the intervention. They also tend to be structured and be administered in a limited number of sessions. Problem Management Plus is an example of a low intensity psychological intervention. It was developed and tested by the World Health Organization, and it is based on 4 evidence-based techniques of cognitive behavioral therapy, which are problem solving, stress management, behavioral activation, and accessing social support. Can be considered brief as it can be administered within 5 weeks with a session per week. It is transdiagnostic. It requires a relatively short period of training of 8 days of the non-specialized personnel, and it requires a low supervision, which consists of 2 hours per week. And of course, it can be delivered by non-specialists and by specialists as well. Problem Management Plus has been tested in 2 separate randomized controlled trials In the first one, which was conducted in Pakistan, it shows that in comparison to enhanced treatment as usual, there was a significant reduction in anxiety and depression at 3 months after the intervention. While in the other randomized controlled trial, which was conducted in Kenya, it showed moderate significant reductions in psychological distress at 3 months follow-up. However, before conducting any studies on the effectiveness or feasibility of low-intensity psychological intervention, researchers take into account cultural adaptation of this intervention. Cultural adaptations are defined as the systematic modification of an evidence-based treatment or intervention protocol to consider language, culture, and context in such a way that it is compatible with the person's cultural patterns, meanings, and values. The aim of cultural adaptation is to reconcile two approaches: the idea that evidence-based interventions apply to all societies without any need of differentiation, adaptation, or change, and the idea that interventions need to be culturally adapted to every person that receives them. At present, there is a large body of evidence indicating that culturally adapted psychological interventions contribute to acceptability and effectiveness of evidence-based psychological interventions. Receiving an intervention that is not adapted to the person's needs have been shown to have repercussions on the utilization of mental health services and treatment continuation, and can be perceived as unethical by some researchers. Advocates of cultural adaptations argue that interventions are composed of three major elements. First is the underlying philosophical assumptions of the intervention. Then is the propositional model, which leads to change. And then there's the procedural model, which are the steps, stages, and procedures that occur within the intervention. Changes to the underlying assumptions and to the propositional model imply that fundamental principles of the intervention have been changed, which may lead to the intervention being effective or not effective. However, cultural adaptations focus on the third, the procedural model, changing the steps, the sequences, the models, language, and metaphors. And this is supposedly, it has been argued, does not affect the integrity of the intervention and does not interfere with the fidelity of the evidence-based treatment. Although many have described the importance of conducting cultural adaptations, less is known about which steps can be taken to conduct them in a systematic way and without bringing any bias into the adaptation. In 1995, Bernal and colleagues presented an influential yet preliminary framework composed of 8 dimensions, which could help guide the development of the adaptation of evidence-based therapies such as Problem Management Plus. The dimensions are language, persons, metaphors, concept, goals, methods, and context. And despite its influences, the framework is still preliminary and does not delve into the specific steps that can be taken to conduct this type of cultural adaptation in a systematic way. In 2013, the Applied Mental Health Research Group at Johns Hopkins University published a very thorough methodology of cultural adaptations of psychosocial support programs. And though the methodology used in this framework is very useful, it could also be considered time-consuming and might not be appropriate in protracted crises when interventions need to be implemented promptly, while time and human resources are scarce. So in this lecture, I will propose a rapid method for the adaptation of low-intensity psychological interventions such as Problem Management Plus. More specifically, I conducted a cultural adaptation of the structure psychological intervention, which is Problem Management Plus, and this was done in Colombia for internally displaced persons and migrants, specifically in Saravena, Arauca. And I am soon going to start presenting this methodology. So I want you to critically assess this methodology and know that it has many limitations, but I also want you to reflect on how you would do it if you were to conduct a cultural adaptation. The first step that I propose in this methodology is information gathering, which basically consists of a literature review of socioeconomic, religious, and cultural aspects of the study populations. This should also include information on the general health and mental health aspects of the population, as well as access to mental health services. And it should also include information on major sources of distress, health seeking patterns, and coping mechanism of, in this case, migrants and internally displaced persons in Colombia. The information gathered in this literature review will be then used in the next step, and specifically it will be used to develop the interview guides that would be used in the qualitative assessments. And I would like to say that this step is also used by Castro and colleagues in a publication in 2010 in the Annual Review of Cultural Psychology. If you want to see an example of how a literature review like this could look like, you could look at the cultural context and the mental health and psychosocial well-being of Syrians, which is a publication of 2015 conducted by the United Nations High Commissioner for Refugees. To develop the interview guide used for the focus group discussion that is part of this second phase qualitative assessment, I of course extracted information from the literature review. And later I also revised the entire intervention following Bernal's framework to determine which parts of the intervention could be subjected to cultural adaptation and integrate questions on these parts into the interview guide. In addition, I also extracted some questions from the framework published by the Applied Mental Health Group that I previously mentioned. So at the end, the focus group discussion lasted 2 hours and was conducted with specialists, in this case psychologists from the Colombian Red Cross, and it basically aimed to systematically elicit and document topics relevant to the cultural adaptation of this intervention. And these included, but were not limited to, types of support people have access to, the mode of delivery of the intervention, word, phrases, the images that the intervention had, as well as common words used to refer to psychological distress among these two populations. As a third and final step of this methodology, we realized it was very important to evaluate the cultural adaptation that had been done. Accordingly, a Colombian and a Venezuelan specialist independently evaluated the protocol of the intervention using the Cultural Relevance Questionnaire, which was developed recently by Salamanca Sanabria and published in Internet Intervention in 2018. This questionnaire is based in the cultural sensitivity and ecological validity theory of Bernal and Helms. I will put a link to this questionnaire in the key bibliography. So now that you know about this methodology that I presented, I want to talk to you about the strengths and limitation of these methodologies. And I also want you to think about some of them, and please feel free to write to me if you think of other ones. First, in strengths, the first would be that this one, as other cultural adaptations, are supposed to, according to evidence, contribute to the acceptability and effectiveness of interventions such as problem management plus. So if we are to measure the effectiveness of interventions, it is important to first make sure that the interventions are culturally adapted to the population to which they are presented to. In addition, of course, this type of adaptation will reduce the mismatches between the intervention and the context in which they are addressed. These mismatches could distract the person that is receiving and providing the intervention and have a detrimental impact on the implementation. In addition, this methodology is systematic, which means that it would reduce to some extent the prejudice and preconceptions that the person that is adapting it has about the population that will be receiving it. Finally, this type of adaptations can be conducted in a short period of time, which is very important in, for example, humanitarian contexts when human resources are time and limited and interventions need to be implemented promptly. Finally, and this is not necessarily in strength, it is important to mention that this type of adaptation is a continuous process, and although it has been presented in steps, cultures and the way people talk about distress and mental health change constantly. That's why it shouldn't be presented as a beginning and an end, but as a cycle. In terms of limitations, I would like to talk about the first issue is that only specialists were interviewed as part of the qualitative assessments. In other cases, it would have been used to, for example, interview also non-specialists and get their opinion on some of the social-cultural issues that were discussed. So in that sense, this type of cultural adaptation could be considered top-down in the sense that it also doesn't include the population that that will be receiving this type of intervention. However, it is important to mention that in humanitarian context, there are implications to including the study population in this type of preliminary cultural adaptation. In addition, I would like to mention that there are other variable methods that could be included into this methodology, such as, for example, cognitive interviewing. And this should not be discarded. You'll find additional example in the Johns Hopkins publication that I will present at the end. Finally, I think it is important for future adaptations to integrate the changes or suggestions from the evaluators. In this case, the CRQ or Cultural Relevance Questionnaire was used only to evaluate what was previously done. However, this questionnaire would include many recommendations from the evaluators that could be implemented if time allows it. So now that you're acquainted with what cultural adaptations of low-intensity psychological interventions are, as well as with the case study that was presented, I want you to answer the following study guide questions. First, I want you to describe the population movement that was previously talked about during this lecture, as well as the role of the Colombian Red Cross in this population movement and in supporting migrants and internally displaced persons. Also, I want you to briefly describe what type of mental health problems occur frequently among migrants and internally displaced persons, as well as what is the main barrier that I highlight in providing mental health services in low and middle income countries. Especially, I want you to talk also about what low-intensity psychological interventions are, and I want you to reflect on what would be the advantages of these type of interventions over regular psychological interventions. In addition, I would like to know if you can describe what Problem Management Plus is and its key characteristics, as well as how would you define what a cultural adaptation is and why do you think it is important. Finally, I want you to describe the 3 phases of cultural adaptation that I presented for migrants and internally displaced persons in Arauca. In addition, I want you to remember that if you read the case study that is attached to this lecture, you'll find it much easier to respond to some of the study guide questions that I just presented. And here you will find key literature on some of the topics presented during this lecture. So please free to write to me to my email if you have any questions. I would like to thank you for your interest and your attention during this lecture, and that you continue to learn about this topic discussed during our talk.